One, we are on.
Yeah, hi. My name is Dr. Kevan Javid, and I'll be hosting today's Global Interdisciplinary Summit webinar. It's an honor to introduce Dr. Sargon Lazarof. Dr. Lazarof graduated as a Doctor of Dental Surgery with honors in 1986 from the University of Southern California, USC School of Dentistry. He currently holds over 20 patents and is continuously improving the dental industry with numerous inventions, including the NUMBI, a needleless anesthesia. His postgraduate studies involved the study of disease of temporomandibular joint at the TMJ Research Foundation, as well as being a past clinical professor at the USC School of Dentistry. Dr. Lazarof is an inventor, developer of the US Food and Drug Administration's FDA's first approved immediate load implant, which has been described in the industry as the first major innovation in dental implantology since the early work of Brannemark. In 1991, he wrote a paper that first coined the term immediate load and described it as a full function at the time of placement. A few years later, in 1998, his book was published, The Immediate Load Implant System, Static Dentistry for the 21st Century by Quintessence. In addition to being a fellow of the International Academy of Dental Facial Statics and lecturing worldwide, he maintains a full-time practice in implantology and is the founder of Sargon Dental and Implant Institute located in Encino, California, where doctors come in and train in both basic and advanced implantology. Dr. Lazarof, it's an honor for us to have you here.
Thank you so much. Good morning to everyone. I hope everybody's doing well in these COVID days. I want to thank GIS and all of you for sponsoring these meetings. I think it's great. While we're sitting home, we can share some information and learn from each other. So I'm going to start with the topic of the lecture. It's basically immediate full functional tooth replacement, meaning walk in, get a tooth, walk out, chew and eat with no specific instructions. So what's the problem? I saw this little video the other day, and I thought it was pretty interesting. So if we're successful in what we do, we have to get rid of that denture. The denture, I always say, it's the failure of dentistry. So in 1991, I did introduce the idea of immediate full functional loading. And for the first time, the term immediate load was coined, actually copyrighted, with the Sargon implant. And I introduced the idea of expandable implants and immediate integration. So recently, we took this to this show. You will see here full mouth reconstruction in 4 hours. You will see here full mouth reconstruction. You will see here full mouth reconstruction. So Brandy sends me pictures every so often, and she's getting into politics. So the question was that, are we able to give a patient a tooth in an hour and basically tell them go home and enjoy? And that's what we do with the Ultra Tooth Centers. Now, currently, we have over 200 Ultra Tooth providers that are certified in the United States that are doing these procedures. And basically, the answer to basic our dream of dentistry, where we can say, "Don't worry, you have a bad tooth. I'll take that out and I'll give you a brand new tooth." And that's what we've been doing. I've been doing that for past 30 years. So let's get into the device itself. This Ultra Tooth has it's made of titanium alloy, 6Al4V, and the expandable portion, as you can see, has a screw, expansion screw in the center, which turns and pulls the expansion cone up. As the expansion cone goes up, the pods move out and anchor into the bone. The surface has always been aluminum oxide blasted and acid etched. You can see the surface. And the design, the current design, which the latest design, we've gone through all the stages of, external hex, internal hex, and all that. And looking back, the best design was the cylindrical. Now we combined all our experiences in past 10 years. We've been using the Ultra Tooth, which has an abutment solid as a part of the implant. So this top part of the Ultra Tooth is actually a 3 millimeter abutment, which has extensions on it. Everything is Morse tapered. Now, the Ultra Tooth also, once the expansion screw is engaged, it has a cover screw or screw cap, which has a Morse taper here. We just put it on and tighten it, and this seals the top of it. So there's no bacterial communication in any way inside the implant. And the abutment has a reverse Morse taper, meaning that the female is in the abutment. And by engaging that, then we have another seal here, which no bacteria can get in the mechanism. And we've seen those systems where it's a screw system. You remove the screw, always the smell of bacteria it is. And then if it's subtissue, you have fistulas and things like that. This can never happen with the Ultra Tooth. So there's 3 seal points. One, the expansion cone, expansion screw seals as it tightens, as you can see this. This is the first seal point. Second seal point is here on top of the Ultra Tooth, and third one is at the abutment stage. 2, and then it's the cover screw that stays on, and the abutment that goes on top of the 3 millimeter pre-existing abutment as an extension, Morse tapers, and you tighten the screw. When the screw is tightened, these two are engaged. You can actually remove the screw and this will not come off. So there's a special abutment remover which you screw it into these threads and pulls the abutment if you need to do that. So we call it a triple seal system. Now, the internal abutment, as I said, it's a reverse Morse taper, and that does away with the flowering of implants. Remember, the Morse taper is and was used inside the implants, but what it does, it's on the smaller diameters, puts pressure on the walls of the implant and causes flowering or breakage of these implants. But in this case, the male is the abutment that extends because we can anchor and we're solid in bone. We don't have to be buried below the bone level. So this abutment is always sticking 3 millimeters above the bone in the healed side, and the sockets is basically level with the soft tissue margin at time of placement. And it comes with a variety of abutments, but the angulation is always same angle as the tooth we extracted, but slightly palatal. We don't put it in the socket. Obviously, if you follow the socket, you'll perf buccally. On most teeth, especially anterior teeth, upper and lower. So the position is palatal. We have special abutments where you can actually, now we have centers that teach the system where, it's a 1-visit Ultra Tooth and a CEREC crown, special abutments for performing that. Now, most of you doctors that do implants most likely have certain implants in your office and say, we're pretty happy with the system and, we can do everything we want with this system. I'm going to present to you 5 things that if your device does not do, perhaps you want to consider an Ultra Tooth in your practice. And number 1 being full functional loading that we've been talking about. Full functional loading at the time of placement. That means no special instructions to the patients, don't chew, small provisional, all of that. We're not talking about that. We're talking about endodontically involved teeth with apical lesions, or you could have periodontal cases, which I'm going to show you how those are treated. And as soon as the lesion is removed, what we do, we go past that bone lesion and expand the implant. And by expansion, we are mechanically immediately integrating this area. And during the biological integration that happens 3 or 4 months later, the patient is in full function. And by that, we can deliver results like this. This is 7-year post-op of number 8 and 9. All of you using implants know what happens with using screw-type implants in adjacent teeth, especially 8 and 9. But look at the emergence profile and the stability of the tissue and bone, and we'll talk about the reason for that, which is not the immediate load, but there's other features. So there are studies on this. The study was published in the Journal of Prosthetics, done by Joe and Hobo, Dr. Joe and Hobo, 40-month study on 275 implants, which they reported 96% success in mandible and 100% success in maxilla. And this is not on selected cases. This was basically on all cases treated. Patient came in for an implant, and they went ahead, they were treated with this device and put in full function. So this is 7-year post-op. I want you to pay attention to this area, maintenance of that bone, which when we overlap it, you can see that's the bone holding the papilla here. So when we immediately can replace teeth, what we obviously can do is preserve their original emergence profile. In other words, the contour of the soft tissue and the papilla, we can maintain that by putting either provisional or final restoration right in that socket. But the question is, now this is the placement, and you can see we can maintain that emergence profile by putting a crown in here. This can be done with a provisional crown, contoured correctly as the original tooth, or a milled crown, where you just basically deliver the final crown at the time of placement. So the question is whether that can be maintained. So we all know that, implant companies always talk about the coronal bone loss around implants, which is typically said that it's 0.2 millimeters per year, but depending on where these screw implants are placed, sometimes it's more or less. The screw is in the posterior region where the forces are directed to the long axis of the implant. The bone loss is less, but as the screw is placed in the anterior and the forces become lateral, you see that cratering, which after a few years, you see bone loss, tissue loss, and actually threads showing and all that. Now, for the first time, we have a device that is wider at the apex. Now, in that 1991 paper that I wrote, I reported that based on the cases that I had seen, I believed that the reason for cratering and bone loss around implants was mechanical, not microbial. So because in all the initial cases that were treated, that I didn't notice that typical cratering that occurs around implants. And that's because this is what we don't want to see, which typically happens with screw and cylindrical type implants. With time, that cratering in the soft tissue and the implant starts showing through and gets worse. So when we did photoelastic studies and you place this device versus a screw, you can see when you expand, the forces are here. And when you put lateral forces, the lateral forces are transmitted apically. This one is clearly showed in the UCLA photoelastic study where an ultratooth is expanded and lateral load is placed on it, and you can see all the lateral load is transmitted to the apex and not to the crestal area. When you have a screw, it's exactly the opposite. It's all here, and that's why the cratering occurs. So also we have finite element analysis that confirms that. This was done by a competitor in Europe, which introduced this type of implant, but he studied the expandable screw types and their own implant, and in their own conclusions, they said that the expanding implant showed the most favorable stress distribution, meaning that away from the crestal region. So what does that mean? It means that these cases that I initially treated years ago, and when I noticed this crestal region, we did not have that typical cratering that, starts, osseointegration starts with the first thread and, keeps going down. I had cases where the collar of the implant, which was treated, osseointegrated, and if the abutment was treated or rough, sometimes we had bone growth on the abutment, as you can see in this case. And that was the older style implant, which was initially used in the 90s. The ultra tooth, I'm going to show you the same effect where you can see these are periodontal involved teeth that are replaced. And basically, when we do those cases, we can guarantee that we maintain the same emergence that is there. You're not going to increase the soft tissue level, but you can basically maintain it where it is. But the growth pattern of the bone, I want you to pay attention to, which is quite different than the screw type implants, whereby you get cratering and bone loss this way. No, you get maturing. That's because for the first time, the apex of the implant is wider and has that Eiffel Tower. We call it an Eiffel Tower effect, which puts the lateral loads pressures here away from the crestal bone area. So we see results like this. Closer view. Now, looking at this case, you can see patient came in with a fractured root canal tooth, an actual tooth here, and what we decided to do is to extract the two bicuspids, put two ultra teeth, make a provisional bridge from the natural tooth, and place a screw type implant and lift the membrane here. And once it was healed, then we went ahead and took the patient from the fixed bridge, which was a full function, and loaded it. And these implants are splinted here. And as you can see, the ultra teeth, the growth pattern of the bone, the maturity of the crestal bone, and the screw type implant, which basically it is a biodent implant, which manufactures the ultra tooth. We do manufacture non-expandable screws, which starts at the first thread, essentially. Now, we did a study on 50 implants with immediate crowns, placing zirconia crowns on them immediately. And this was a hybrid material that we were using that a company came in and gave us these hybrid material, which we made shell crowns, and then we relined them with composite, and we delivered them immediately. And what happened is that after about 5-6 years, we started seeing fracture in these crowns. So we had quite a few of these ultra teeth that had to come back, and the crown had to be replaced. So this is a case where 7 years post-op came in with a fracture that the crown had to be changed. Now, when the crown was removed, and I'm taking impressions, I want you to pay attention to the emergence profile, the papillae, and the contour of the tissue at the time of impression, taking 7 years post-op. Okay, now these crowns were delivered, and then we had opportunity to get 14 years post-op, 7 years, 14 years. I want you to see the level of the bone and how the bone basically stopped at the crown, the margin of the crown. Right here. So it's a great phenomena, basically, that we can not only say to the patient, I'll give you a brand new tooth, you can walk out and chew and eat. We can also guarantee that 5, 10, 15, 20 years, 30 years, which I have cases, you will not see changes in the soft and hard tissue contours. As a matter of fact, I had a case which was number 8. It's interesting that I had done was the third ultra tooth I ever placed. The patient ended up coming years later to my office, and he lost all his teeth, and number 8 still had that emergence, and the crown was fractured because the doctor that wanted to put a denture, he put a forceps thinking it's a tooth, and we basically fractured the crown. Now, another phenomena that we were noticed, and the studies in University of Indiana confirmed, was increase in bone density by expansion and actually compaction of the surrounding bone. So just like this pattern of circular pressure that occurs in the surrounding bone at the apex, same thing was observed in the histological studies, and they called it an oscillation effect. Same circles appeared, increased density in the surrounding bone. So the zone around the ultra tooth actually improved its bone condition. What did that mean? It meant that cases where, we had adjacent teeth that were loose, all of a sudden stabilized just by putting an ultra tooth adjacent to it. Now, this is a case where the patient had gone to periodontist, had treatment a long time ago, and then came back a few years later with pockets. This implant was too close to this root. This tooth was painful and had some bone loss. Went back to his original doctor. The treatment plan given was to extract, remove all these implants, do bone grafts, put them in, partial dentures. And this patient is a pretty famous actor that did not want to go through that. So when he came into our office, what we did is that we removed the anterior tooth, placed an ultra tooth, refreshed and cleaned the surface of these implants, and grafted the area, and actually provisionalized the entire area with fixed provisionals. The additional implants was placed in the anterior area that was treated. So, and then the patient was sent to the referring doctor. We had the other side that one tooth was bad. Basically, the fixed provisional was placed in the anterior, and then this is post-op when the crowns were delivered by the restoring dentist. I want you to pay attention to the bone around the ultra tooth, and also the improvement of bone on the adjacent implants that were planned to be removed. This is another case that walked in our office. This was a case treated with a screw implant that had gone through block grafting, soft tissue grafting, and they had a couple of failures, removed, and it was a 3.5-year process where the patient came in, tears in her eye and very dissatisfied. As you can see that, she was talking about that I was tormented for 3.5 years. Now they tell me that this tooth is loose and it needs another implant. And what do I do? And think about this case where actually 3 different practitioners had worked on this tooth, and she's sitting in your chair and she wants you to tackle this. And I want you to ask you a question: that how many of you would even get involved with a case like this? Well, with having the ultra tooth, for me, it's very easy because I know that not only I can give her an immediate tooth here, but by placing a ultra tooth here, I can actually improve the condition of the bone in the surrounding area. So I want you to look just by basically removing and placing an ultra tooth before. What I call this is an angry tissue. You can see the color of the tissue and how it's basically going away from everything and wants to kind of reject what's going on here. This is post-op with the provisional, and this is 4 weeks post-op, as you can see. And I want you to pay attention how an ultra tooth maintains the surrounding bone versus a screw that does its typical thing. So now here, compare the tissue levels, and then look at the bone level. All right. You say, we're manipulating X-rays and different angles, maybe to make the ultra tooth look better. But what you cannot deny is the fact that the papilla is actually starting to come back here because of this bone versus that. So this is where we were at 9 weeks. And I asked the patient if she would allow me to start grinding away this pink tissue, because what it looked to me is that this tissue is happy now. It wants to kind of drop down, and this person was preventing it. And she said, no, I'm happy, perfectly, it's fine, don't touch it and everything. Well, we left her as it is. So this was the result, a single visit ultra tooth placement versus 3.5 years of grafting, block grafting, and removing and placing tissue and all of that stuff. And you can see how much we can save the patient time and torment. And by doing that, look at the financial aspects of it. So what would you think if I told the patient that I would charge you the same for this ultra tooth, for these procedures, but I'm going to do it in one visit and this is the result? You think the patient would say no? This is the final restoration, 9 weeks post-op. This is a case that was sent to us. This is a type 4 bone, and we can tell by when the ultra tooth expands fully and the expansion cone is all the way at the bottom. And this was allowed to heal, but then after loading, obviously when it's type 4 bone, we don't suggest immediate loading. But this case was done with a combination of implants, and the doctor sent it to me that said, basically the 4-unit bridge was being held with the ultra tooth and these had failed. So we also have 30% more surface area compared to equal size screw implant. And that's, again, this is another study that was done in Paris, showing osseointegration inside and outside the pods. And look at this, how the bone goes through here. And by measuring that, you basically you have 30% increase in the surface area. By the way, one misnomer is that, how would you remove this? We have a device that basically reverses this and pushes this expansion cone out, which pushes this bone out. And once this is unscrewed and this is down, these legs are unsupported. So when you send the trephine, let's say if it's a fully integrated implant, we often get this question that, this device is hard to remove. No, we have a device where basically trephines and closes the pods once this is unscrewed and pushed down, and you can remove it just like a cylindrical screw. It's trephine out if necessary, which I myself have placed over 17,000 implants. Maybe on my own cases, I've done that maybe 4 or 5 times. If an implant fails, you can remove your fingers, but you normally don't trephine a fully integrated implant. But the question is always there, that how would you remove a fully integrated implant? Anyway, so perhaps, reasons behind why an Eiffel Tower effect versus these 2 screws. Another case that was sent to us by another treating practitioner had 2 implants of different kinds and put them next to each other. And after a few years, this was the X-ray that was sent to us. Now, we do have, as I said, non-expandable implants where when we do sinus lifting and the entire bottom half is in the sinus, so might as well use a screw if you're going to, push it in the sinus and try to get bone healing. But in this case, if the screw fails after loading, we went ahead and used an expandable, expanded that bone, and took care of the situation. And now this is 1 year post-op. So quickly, let's see how the ultra tooth works and is placed. Here we have animation view of extraction. What we try to do is to do an atromatic extraction. Now we have different types of instruments, electric mallets, and all kinds of things. But if you I basically use small elevators paddlessly to luxate the tooth and then remove it. If we can, we want to maintain the contour here. Now, if the bone does not have any lesions or openings, we do a closed technique. You can do it guided. I suggest learning it, free-handed, because we get a lot of emergency cases. Patient walks in, they want a tooth right away. So both techniques are available, guided, or you can learn how to do this free-handed, basically using the socket as your guide. 2 drills are used. We have a universal patented drill that does the job of 4 drills. And then you have the final drill. This one is sometimes used if you use a wider platform abutments. You want to make room for those. So here you can see the ultra tooth is basically screwed in. I do this with hand half of the way, remove the hand wrench and use a ratchet to drive it in. Then the carrier, which can be an abutment, prepped into an abutment right away, is removed. So in order to loosen the carrier for the more taper that is here, sometimes if it's too tight, you just unscrew the screw underneath it that does that. This is the cover screw or the screw cap, which seals the top of the ultra tooth. And we basically leave the screw cap in because we want bacterial seal here. Remember, we talked about the triple seal that we do have. So here, the device is expanded 20 newtons. So torque wrench breaks at 20 newtons, regardless of where you place it. It's always 20 newton, any size ultra tooth. It's just that the amount of expansion changes with the quality of bone. Obviously, in type 4 bone would be full expansion. And if you have type 4 bone, we don't recommend immediate loading, but while leaving the device to heal, because of the expansion microfracture, you increase the density of the type 4 bone, and you have higher success rate than just putting basically a screw in that. Now, in this case, that carrier is prepped in the abutment, and you can do just scanning or cord impression of that, send it to the lab, or if you can scan it with your milling unit and make a final crown there. So I'm going to show a closed procedure. I'm going to go through this real fast because of the timing. When we don't have any lesions, any fistulas or anything, and when we take the tooth out, when we clean the socket, there's no opening into the buccal area. In these cases, we can do a closed technique. So basically, we go in there and clean the socket. I use an ultrasonic. And here I'm disinfecting the socket with ozone oil. This is the universal drill. As I said, does the job of 4 drill, rosette, pilot, guide, and all the way to the final diameter. So as you can see, the direction is the same direction as the tooth came out. Just palatal, the finger on the buccal, make sure that there's no perforations or anything, that I'm feeling for vibration right here. And then the final drill goes in. And basically, we line up the hub of the drill to the soft tissue margin for 13 millimeter implants. We have long final for the 16 millimeter implants, which are the 2 implants that you use in sockets. Obviously, you don't use a 10 millimeter because 10 millimeter will be essentially in the socket. So what you need, 75% of the ultra tooth to be in contact with prepped bone. So that includes the area in the socket. So right here, This is the ultra-tooth packaging. I'm going to go a little faster here. And the ultra-tooth is screwed. As you can see, as it bottoms out, it kind of initiates that lock, that expansion. So here we go. This is all going in. We remove the carrier. Screw cap is removed. And the ultra-tooth is expanded. As you can see, at the time of placement in the extraction socket, the top of the abutment on the ultra-tooth, which is the 3mm on top, is basically level or a millimeter deeper than the soft tissue margin, regardless of whether the buccal plate is there or not. If the buccal plate is not there, we can graft. If the gap between the buccal plate and the ultra-tooth is greater than 1.5 millimeter, we can fill it and graft it. So when blood comes in, it uses graft material scaffolding to build bone and maintain the buccal plate. So here we're expanding to 20 newtons. You can never go wrong with this. If you overdo it, if you go beyond 20 newtons, around 25 newtons, the screwdriver, it's a slotted screwdriver, it will bend and you can actually change the tip for your screwdriver. So you cannot do any harm to the ultra-tooth because whatever is inside is much stronger than the instruments that you use. So we're at 20 newtons here. So here, the screw cap is placed. And then we have a provisional abutment that gives you an extension of that abutment that is inside the mouth, which is already in the implant box. That to provisionalize, you can just remove that and screw it on top. You can take your final impression if you desire at this point. There's a snap-on type of impression. You snap it on and take impression and send it to the lab while you put this provisional abutment here and make your provisional. Now, check the occlusion. If there's any interference, this is the time to kind of make sure that there's room. And we go ahead here and provisionalize. Provisional, always composite. We do not use any methyl methacrylate because acrylic can go down, and 25% of the population are allergic to methacrylates, and they get softening of the bone, and you have to re-expand the implant. Always composite. And I want to show you an example of an open case where we have a fistula. We treat patients that have problem teeth. It's not healthy teeth that we extract. With the protocol of immediate provisionalization of the screws, you can imagine what they require with the bone being, all intact and solid. Here, we have a lesion that actually has grown towards the lateral, and it split the root. Now, when I remove this tooth, you will notice that the piece of the root is still in there, and there's no buccal plate. The entire buckle plate on the socket is gone. So this would be an open cage. I put one vertical cut, open it up, clean everything. You can see the entire buccal plate of the tooth is gone. We want to make sure all the soft tissue, the lesion, and the junctional epithelium, everything is nice and clean. Now we don't rely on that buccal plate, that socket for our stability. What we do, this is a universal drill that creates a brand new socket palatal to the old socket. So our ultra tooth goes in here, and this is one of those cases where we talked about putting the immediate crown on it. So while I was doing the bone grafting, I took a impression, and basically it's just the index. The lab already has the impression, so I indexed the implant with the adjacent teeth, and the lab had a hole where the implant was. So basically, they put it together. Obviously, this is years ago, and I'm going to show you the pattern of bone years after. So here we placed and expanded the device, and here the healing collar is here. I'm doing the grafting, and the lab is making the final crown. So this is BioOS collagen, which I basically mimic the contour of the bone that was there. So I build that from the BioOS collagen, and then as a membrane, I use calcium sulfate mixed with tetracycline, and I cover this and make sure it's nice and dry. That would replace the membrane. You can use a resorbable membrane if you like. Now here, the calcium sulfate that I placed there. And the trick to using this is a dry field. You want to put a 2x2 on this and have it get that initial set. So once you remove the 2x2, this is what it looks. And we go ahead and put the tissue back and put some resorbable sutures here, and then some silk sutures on the flap area. And by then, the prepped abutment and final crown should be ready. So you go ahead. I'm going to just forward this a little bit. You can see here, sutured. Now the crown comes in. I'm placing the abutment and cementing the crown. Crown is ceramic. Picks up the darkness of the tissue. When the patient comes back, she'll be a better match because right now it's picking up the tissue color. Now, patient at the time of surgery, right after the surgery, patient is given an apple to bite on. As I said, our stability comes from that brand new socket and that apical native bone that is there. So presence of a buccal plate is not a requirement for us, and the device is always put in full function. So patient can bite on the apple in the surgery room, and we're not worried about anything. So she hasn't been biting on that tooth for years. She was amazed that she could actually bite. This is, you can see 10-day post-op when we remove the sutures. The implant tests, and if you use the Ostel unit right after expansion, the stability goes to 70. From 30 goes to 70, and it remains there. Periodically, you check it. So this is 6 weeks later. I want you to see contour of the tissue, the papillae, And this is 4-year radiograph. Again, pay attention to the bone, past the threads, color of the implant, and where the margin of the crown is. Look at the bone growth on that. So surgical positioning, quickly, just basically you can see we ignore the apex and tooth is placed parallel to the old tooth and just palatally. These are different positions that we show you, and the placement diagrams. 2 drills basically do the prepping. Can do molars. This patient came in, fractured tooth. We go ahead and actually do the preparation right through differentiation where there's available bone here. Replace the ultra tooth. Once the prep is done, you do the extraction and graft the adjacent sockets. And because we have enough stability here with a 13 millimeter wide, we go ahead and actually fully functionally load. So I want you to meet Dr. Blinstrup, a military dentist that one day was sitting in a bar and someone came in and punched him in the mouth and knocked out 4 teeth here. It was an emergency room. They wanted, and also the palatal bone was fractured here. They wanted to remove the palatal bone and put him in flippers. He said, no, stop, don't touch, and just clean me up and send me to Dr. Lazarof from Arizona. Flew to LA. His father used to be a patient of mine, and that's how he knew about us. And then he came in. This is the condition he walked in. And when I took the CAT scan, you can see the 4 teeth missing and this piece of bone here that is fractured, the palatal, and it's just hanging there. The soft tissue was holding it. Treatment plan with 4 ultra teeth. Patient, the ultra teeth was placed and that bone was sutured. We have so much stability here. I used the ultra tooth to stabilize that bone here, and the patient walked out with provisionals, functioning provisionals. I cleaned up the lip and sutured it again. And this is the healing that he sends us pictures from Arizona. And this is what we have. 3 months post-op. Look at the level of the bone. Imagine if this patient had allowed them to remove this bone here and put a flipper there, how difficult it would have been to regain this length here, and how long it would have taken. This patient, right after we gave him this, had fixed provisionals, and then this is 2 years post-op, and we're happy to say that Dr. Blinstrup recently, he went to dental school and 4 years of military, and he's back in LA and will be working for our Ultra Tooth Center. So now we have many different types of cases that I'm just going to go through. I have a few more minutes here, and you can see these cases, old and new cases, and how they were treated before, after a single visit. Patient with a pus, apical lesion. All you have to do is make sure that this lesion is removed and the socket is disinfected. The cause of the lesion is removed, which was the tooth. You go ahead and you use this bone to stabilize the ultra tooth, and these cases heal and fill with bone. And as you know, typically they call you crazy if you even thought about treating something like this with a screw implant, placing the screw implant with this lesion there. You'd allow this to heal, probably collapse, and then probably in this case you'd have block grafting. This is a more severe case. This is a through and through bone loss. You can see there's a hole in the palatal bone all the way. But same idea. You just make sure that you want to use a long enough ultra tooth. You pass by this area, expand, immediately provisionalize, and rebuilt the area. And you can see with time, basically all that bone heals and the lesion heals. Periodontal cases, patient comes in, you just want to make sure that the junctional epithelium surrounding these teeth is all cleaned up and removed. And these are cases that are treated full mouth. This is another famous singer, which was told that she had to have everything taken out and have dentures. She was having nightmares. The time she was living in Europe, she came in. We treated the four anterior teeth first to show her what we can do. This is years ago. This was the external hex implant. This is at the trying stage, the x-ray, and you can see case was treated, eventually became a full mouth. Only we had 2 or 3 teeth that were left here, natural teeth. Everything else became implant. If you have a collapsed tissue, this tooth is extracted, but there's enough bone to do the procedure. We have the tissue fold technique. Basically, place the device, provisionalize, and take this flap to the palatal area and just fold it on itself, suture it, and right here, and you get nice healing of these situations. You know, in the posterior area, you do extraction, you can place it in the palatal root, which is in the sinus. This would save you a sinus graft. These cases are not loaded immediately, but basically by placing a ultratooth in the palatal root, you're avoiding a future sinus grafting procedure by allowing them to heal. So in this case, I just put a custom healing collar, the abutment and composite made a custom healing collar, so we can replace the tooth exactly with the shape of the tooth that came in. Sinus lifting, as long as a portion of the pods are in the floor of the sinus, you can do it with the ultratooth. That gives you a lot of stability here. But if the entire pods are in the sinus, might as well use a screw. This is a VIP that was flown to our office. Basically, in 2 visits, we replaced all the teeth. 28 teeth were extracted, periodontal case. And 1 arch was done one day, and a few days later, the lower arch was done. Basically, after like 12 days, the patient returned to his country with full upper and lower restorations. This is at time of delivery, final crown delivery. And basically, where the tissue was, we keep the tissue. So 3 questions that always come up. We talked about removal, very simple. There's a device that, you know, you can back up the center screw, pushes the expansion cone down, taking the bone out from inside the implant. We're talking about the fully integrated implant. And when the trephine goes down, it closes the pods and brings it down, and the remaining hole is just a 4mm diameter of the original implant. Implant seal. The question is always used to be that, you know, as far as bacteria traveling through, now the ultratooth has a triple seal that we talked about. Not only it has, this is showing the removal. As you can see how these were removed. As far as the seal, the initial seal on the external hex was right here in this screw, but what we did is added 2 more seal points. This was for FDA approval. 1994, this device was and is the only FDA approved device for full functional immediate loading, and they required us to show the seal, internal seal functioning, and then they asked us to do fracture testings to make sure that the strength of the pods and everything is good. So this is the triple seal that we introduced 10 years ago with the Ultra Tooth. Not only we have the seal here, we have the seal with Morse taper with the screw cap, and then when you place the abutment, that's a tertiary seal that occurs there. These were been tested at pod level. They had to pass certain number of hits and pressure and all of that. And they all showed when we pushed them to the failure and bending, they were double the original screw that they were compared to. So I'm going to stop here, and we're going to see if there's any question.
Yeah, hi, Dr. Lazarof. Great, fantastic presentation. Thank you. Yeah, there's some questions. Our first question here, Dr. Basim Shakir is asking that he's been placing some of your implants from years ago, and it was difference. And it's a different function, basically.
The Sargon implant, the original Sargon implant, had an external hex, and it had one seal on the inside. And we used to recommend that when you put the abutment, you use silicone to seal the abutment screw as a secondary seal area. Now, we had occasions where some doctors would place the implant and not even expand it because they said it was stable. In these situations, if the center screw was not expanded to 20 newtons, you actually did not have a seal. So we redesigned it in a way where not only with putting the abutment on top of it, putting the screw cap on top, not only we made sure that if you don't expand it, you're still sealed, and if you don't actually put the screw cap, you can't restore it. So, and also we went back to the cylindrical design that the original Sargon has. Later on, we went to the tapered design, internal hex and all that. And evaluating all my cases, about 10 years ago, I realized the original cylindrical design, not tapering, had the best soft tissue maintenance because the wider the implant becomes on top, there's less room for bone formation. And if the bone under the tissue doesn't develop, with time, the soft tissue receded. So the cases that were done with the internal connection with the wider platform, we noticed that with time, always the tissue was at the level of the top of the implant, and if the implant was a little lower than the adjacent CEJ, so there was a tissue deficiency. The lower was lower. So we changed to the cylindrical original design with the solid abutment on it and introduced the Ultra Tooth 10 years ago, and I've been using it exclusively, and that's the most stable one, which with time, you do not see any changes in the hard and soft tissue.
Amazing. And
also, we made it self-tapping. Sorry. We also, the Ultra Tooth is self-tapping. The original Sargon, you had to pre-tap the bone. And we had people using the Sargon implant, original one, to tap the bone, and it wasn't designed, and in the hard bone, they would actually bend the pods. But the current design is self-tapping.
Got it. Perfect. So next question is, are these implants available internationally? And if it is, where can the doctor go if they're interested to find out more about it?
What we did is we introduced this device, Ultra Tooth, to the market 2 years ago for the second time. And because originally when we introduced it, there was issues where the competitors paid off the institutions that did the studies. There were litigations, patent litigation. So we introduced it 2 years ago. We have 200 centers that are certified in the United States, and we wanted to be present in the United States. And it's only now that we are starting to look into distribution companies for international distribution. So if there are people interested in companies, we are ready to do that now.
That's perfect. Perfect. You kind of answered most of these questions I see here. Questions about removal. Another question was about you place these implants subcrestally, like an ankylose.
Yeah, the implant in the socket, we don't look at the bone. When we treat sockets, we look at the tissue level because we always are able to maintain that. Even if the buccal plate is not there, the top of the implant goes to the tissue level, meaning the 3 millimeter abutment that is solid on the ultratooth is below the soft tissue. Now, if we need additional length, we have an abutment that adds to it. But by placing it there, everything falls in place correctly. So you're looking at the soft tissue level when you're drilling, and not looking at the bone level. And the healed sites, obviously, you put it. The threads are going to be bone level, but the abutment, the 3 millimeter, is sticking above. So again, usually the abutment is in the tissue, soft tissue, on the healed site, and the threaded part is below the bone.
Below the bone. Got it. And then last question about the material you use for your grafting and the membrane. You're always using.
I always use.
Huh?
Yeah, I always use BioOS collagen, but lately what I've been using is PRF, and adding sometimes BioOS particles to it.
Got it.
So yeah.
The membrane, yeah, you use calcium phosphate. You say calcium.
Calcium sulfate. Calcium sulfate is plaster of Paris. And this is something that USC did a long time ago. And you gotta make sure it's a type that actually sets. So you mix it with tetracycline. With a dry field, you can just form a cast over your bone graft, and it holds everything together, and it works very well for me. And it's very cost effective. Yeah.
Perfect. This very exciting presentation. You do full body reconstruction in 4 hours, and then your patients are able to eat an apple immediately. That's amazing. I have to try that.
Exactly. Yeah. Anyway, I'm due to come to your the Palm Desert office, and I've promised to come there and turn that into a ultratooth center. So we'll be doing that.
Absolutely. That's great. That's great. Perfect. Thank you so much. I enjoy having you.
Thank you. Thank you. Thanks, everyone. Bye-bye.